Nikhil, thank you for inviting all of us over here. And thank you, Astra, for giving me the opportunity to discuss the non-small cell lung cancer. Last time I discussed the small cell. Now this is the non-small cell. Okay, so let me invite my panelists, Dr. Kumar Prabhash. He was there just now. Dr. Rohit Pai, are you there?
No, sir, he is not there.
He's not there. Okay, so let me just put this off. Murtuza Bora.
Yes, sir.
Yeah, you are there. Satyam.
Satyam sir is not there.
Satyam is not there. Rohit Pai is not there. Shruti, I saw her giving a talk. Shruti, you are there. And Dr. Akash Tiwari. Yeah, Dr. Akash Tiwari. Akash. Akash, organizers say Akash is there or no? Okay. So are you able to hear me?
Yes, sir.
Yeah,
Yes, sir.
I thought suddenly everything, nobody is responding for Akash also. So I thought whether I'm not able. So I think Akash is not there probably. So let me start with the first, Kumar. So in the Tata Memorial Hospital, now what is the lung cancer panel? So, you are asking for all the patients. I know that, at the teaching institution or at the institution which is busy, so there might be some restrictions in asking. So what is your choice of the markers, what you ask for?
Sir, at this moment, we are doing EGFR, ALK, and ROS and PDL1 for almost all patients. Till some time back, we had a NGS which was available easily for us for NC patient, which used to be around 2000. So we are able to do for all. This time there have been cost revision and that has limited its use. But what I said earlier, that EGFR, ALK, ROS, and PDL1 we use for all patients. Sir.
So Shruti, you use these 4 or something else you add?
We do add once.
Yeah, Kumar, yeah.
No, I got it, sir. It was for Shruti. Shruti, please.
Okay, sir. Sir, so what we do in our hospital, Maheboob, sir, actually we have created small panels for ourselves depending on the patient profile. So we have a restricted panel where we do EGFR, ALK, ROS, MET. That is the basic panel we do for everyone. We do not do BRAF, HER2 or PDL1 in those poor patients. And then we have a NGS panel which is costly for we do for well-off patients who are candidates for BRAF therapy or PDL1 based this thing, and which and include HER2 also in that. So we have made small groups of panels for ourselves so that we don't say no to molecular testing for any patient.
Okay, so everybody is doing their own bit of things so that the patients ultimately get benefit. Murtuja, do you do liquid biopsy upfront for all the patients or selected patients? How do you do that?
Sir, not upfront. When on selected patient, like when the tissue is not sufficient and the repeat biopsy is not possible or very difficult. At sometimes patient preference also, they don't want to undergo repeat biopsy. Then we can think of the liquid biopsy. Otherwise, I generally prefer tissue block only.
Okay. Anybody else has different thought, Kumar?
Sir, I agree with the comment, except that in case if the resource is not a concern, then it is good to do both because you will add some in both ways if you do. But I do agree, by and large, there are very few patients when I explain them, they end up doing it. So usually if you have to choose, then tissue is the priority.
Okay. Shruti, as you might be doing PET scan for all. So when do you do MRI brain? For symptomatic patients or asymptomatic patients?
Sir, for symptomatic patients only, sir.
Only. Okay. Otherwise,
or non-metastatic. Yes, or non-metastatic. That's it.
No, and we are looking at metastatic disease only. Yeah. So for the patients, as they have undergone the EGFR and other targetable mutations, and the patient has found to be an EGFR mutation, and now we have various options, either to give first, second, third generation TKI monotherapy alone, or EGFR TKI with angiogenic drugs, or EGFR TKI with chemotherapy in combination. And so these are the three basically an options. But the fourth option, Kumar, let me ask you, why EGFR TKI plus immunotherapy has I mean, there are no phase 2, phase 3 trials?
Can you repeat, sir?
No, the fourth option, which is not here, but EGFR TKI plus immunotherapy.
Oh, EGFR plus immunotherapy. I agree with you, sir. I think so. That is something because they have not been able to show that. Looks like there is some additive action with them. There is an issue regarding complication. The additive action requires VEGF inhibitor, so that complicates the thing, sir. If one has to give it, till recently we thought looks like immunotherapy may not work with them. This TKI mutation when we give TKI and when we add chemotherapy, but there is some merit to it. But you have such good options otherwise. That's why at this moment, first line, that option is not there. In spite of two options being there, which one can consider, which is available at present. Yeah.
So in second line, because there
second
is
line, yeah, second line, yes, sir. Second line, yes, sir. I agree. ABCP is there, and now there is a validated data from Chinese trial. One can use it. I have used in some patient, but it's a bit complicated, sir. I always keep saying, I keep using this word. It is like treating like ALL patient.
Yeah.
For drug.
Conflicting data, yes. Osimertinib along with bevacizumab in second lines, it is positive. Some patients say that there is some people say that there is hyperprogression, so one should not be using it. So there are different. Murtuza, when you are starting treatment with the EGFR mutated patient, so what do you look for? Efficacy, safety, QOL, or all?
Sir, majorly efficacy and quality of life, because we know all drugs are more or less safe, but quality of life definitely matters, because I have seen that decometinib having the worst side effect profile compared to the all TKI, EGFR TKI. Because I'm a PI of decometinib trials, I have seen majority of patient has skin toxicity and diarrhea, at least with the third generation TKI. That's why I will go with the see the quality of life as well as the efficacy.
Okay. So let me ask all three of you, what is your preference, starting with the Kumar first, whether you use second generation TKI, then move to the third generation, or first generation with anti-angiogenic drug and then third generation, and we know you are the champion of the TKI plus chemotherapy and then to third generation, or osimertinib upfront. So what's your choice, personal choice? You're mute.
If I have all the resources available, third generation TKI because of efficacy and the safety,
Yes.
but the real world is that only 5 to 7% of the patient they can take it. Now the issue remains, what is the choice? For those rest of the 95%, what we know that first and second generation TKI, excluding decometinib, is inferior to other 4 choices. And out of other 4 choices, either you take decometinib, or you take VEGF inhibitor combination, or chemotherapy combination. Chemotherapy plus TKI combination turns out to be the cheapest and most affording for the patient with a similar outcome. So that's a overall concept for me. But I won't debate with anyone if they chooses one way or other. But that's the concept I suggested.
So how do you take OS benefit of more than 50 months with chemo?
Yes, sir. You have more than 50 months. Okay. So that is a Japanese trial always with Jeftinib also. The Japanese trial, the median survival was 30 months. So our trial, the median survival was 20 months. And take Western world trial, median survival was around 20 months odd.
Yeah.
So they have always had those differences in the outcome, but the proportion difference has remained the same. And our overall survival data also suggested the same. We have just updated. We are putting in ASCO, and I won't say the number, but yes, it looks substantially improvement in survival proportion wise as compared to Jeftinib. So yes, it does improve survival. So now you have a at least 3 options which improve survival, and that's one of them. That's a chemotherapy combination. That doesn't mean to say I'm saying that is the only choice. Sure, patients, when I discuss my patient, majority, if they can afford, they want tablets, and especially the safer ones.
Okay, Shruti, what is your choice? One,
Yes,
two,
sir.
three, four.
Yes, sir. I totally agree with Sir Kumar, sir. First choice is number 4, third generation osimertinib
Okay.
upfront.
Okay.
Because I've seen many patients who want to take OSI and just die with brain metastasis even before the report of T790M comes. So I don't want such a situation for any patient ever. And so it is my duty to offer it to all my patients. Then in the other options, chemo plus TKI is I use it very frequently, and it is very well manageable with some dose reduction for pemetrexed. So DACO and afatinib even, the safety is an issue, and full dose tolerance is always a problem. So I also go in that sequence only, like Kumar sir mentioned, sir.
Okay, so Murtuza, you were
Yes.
the PI, as you said that for the documentary. So dose reduction was not there in the trial?
So, no, so dose reduction was there, but still after dose reduction, majority of patient has tolerate only 15 milligram. They're not able to tolerate 30 also. And
Okay.
all like skin reactions and diarrhea, these are the most frequent this side effect. And patient, none of my patients is on full dose. Like majority has on 15 and some is on 30. So just want to add one thing, as
Yes, please. Yeah.
Dr. Subhash and Dr. Shruti has mentioned that if the patient is well affording, then we definitely go for osimertinib. But if the patient is non-affording and still having the brain mets and want the and PS is not very good, I will give the first or second generation TKI with angiogenic inhibitors. Because if you see the blood-brain permeability of bevacizumab is compared higher compared to the other chemotherapy. So is this combination also a viable option for brain mets patient, those who are not affording for osimertinib? So we can give, we generally use in our poor patients. Poor, that means those who can afford angiotensin inhibitor but not osimertinib.
So if they can afford bevacizumab,
Can I put a
obviously
number to it? Can I put a number to
Yeah.
it? So,
Yes,
you know, in principle, I agree with you.
Yeah.
But let's put some number to it. One is brain mets were included in that study where chemotherapy TKI was given, and the proportion benefit doesn't change. It remains the same. The similar data for angiogenic agent is, you know, we want to see that. Theoretically, it is good what you said. Second part of issue remains, if you're giving 15 milligram per kg body weight, and let's take 60 kg weight of the person, of that patient, then you are end up giving almost, it will end up around 50,000 rupees or 60,000 rupees per patient cost.
yes.
Again, we have to find out, we have to bit concerned about how long the patient will be taking it. Then again, comparing those outcome with those ability to deliver comes in the question. That doesn't mean I'm saying that's not an option. Sure, that's also option.
Completely agree, sir.
Yeah. So the last about these, the Kumar, the data of OSI with bevacizumab didn't show much benefit. So theoretically, if it is better, then why not did it show benefit?
So I agree with you, sir. And one of those explanation was this question has been discussed by some other people. Looks like bevacizumab benefits when TKI doesn't work so well in brain. And here the problem is that osimertinib works very well in brain.
Yeah.
So that benefit, what we want to extract from bevacizumab in brain doesn't come here. But I do agree with you that this questions the I always say the concept. But I think so. Good thing is that that concept has been also answered in 3-4 trials now for bevacizumab and also for ramucirumab. So it looks like VEGF inhibitor does something. Maybe we can't overrule when we combine with first and second generation TKI. But yes, osimertinib data does put a dampener, and we need to be a bit careful. And that's why someone commented it will be important to see what happened when osimertinib is combined with chemotherapy.
Yeah.
Yes, because is it true that gefinib it works, then we combine with osimertinib, it may not work. So
yeah. So if you look at the earlier trials of erlotinib and gefitinib, the exon 19 deletion 19 and the 21, the results, they were not difference, but we know the difference is there with the afatinib and the other. So Shruti, what do you think? These drugs work much better in the exon 19 deletion, or what is happening?
Sir, I agree that there is a difference which is not seen with a third generation TKI. So I mean, it's
No,
hard.
there is a difference seen in 19 and 21 with third generation, but not with the first generation.
Not with first generation, but I don't see why it is. I mean, like with second generation also we see that difference. It is not there with the first generation. I think I mean, like can't comment on how that is happening. Maybe at some pharmacokinetic level. I mean,
Kumar, any thoughts on that?
Sir, I think so. With the previous generation TKI, what we have seen that proportion of benefit is similar. Prognosis is different. So exon 21, the prognosis is poorer than exon 19. But for example, I just giving a analogy that if the PFS was 5 months with chemotherapy, the improvement is 20%, and 6 months with chemotherapy for exon 19 and 5 months with exon 21. The proportion difference is similar. The absolute number changes, so prognosis is, becomes different. Yes, what you are raising a question, sir, that if we take dacometinib and if we take ramucirumab, I'm just naming it to make it explicit. Is there a question regarding that exon 21 and 19, the benefit, that part changes, and then it starts overcoming that prognosis what we have? So I always say that's not a clear-cut answer to it. But when you have a 5 option, we all start choosing, and I do believe in that you have a 5 option, choose 5 option where you want to use. Otherwise, those modalities goes out of window completely. And I always give example of high dose interleukin. We didn't use it. It was there in Indian market. Now it is not there. So I say yes. That makes a bucket out of it. For this bucket, we can use these kind of drugs. But we are creating the bucket rather than it's being. It's been proven to be there.
So theoretically, people are saying
some merit. Yes.
Yeah. So there are co-mutations.
So brain mets is there. 21 is there not.
So theoretically, there are co-mutations associated more with the exon 21 as compared to 19, and that's why survival of 21 is lower compared to 19.
Sorry, sir, we missed you.
Can you hear me now? I will put my video off.
Yes.
So,
no, sir, go ahead. Sir.
Yeah, now, I mean, the mutations associated with exon 21, the co-mutations are probably higher in number as compared to 19. And that's where the survival of 21 is supposed to be a little lower compared to 19. 19 do better. And that's the drugs like osimertinib, etc. They have a better coverage for all these mutations. So they are doing better. That's what the theoretically possible. So
yes,
we know,
yes,
we know in flora there is a very important. We already discussed about the sequencing. Everybody wants to go ahead and give the osimertinib first, the third generation, because Shruti said that many patients may not be able to go to the further treatment ritual because of the brain mets and other things. So we would like to go ahead and continue the treatment with the other things. So what happens if somebody progresses on the osimertinib? Let me ask Murtuza. So what's your choice of treatment when somebody progresses on osimertinib?
So generally, I give the conventional chemotherapy like pembrolizumab or cisplatin based dual chemotherapy if patient's PS is good.
Okay. Oh, okay. You don't use immunotherapy or something like that? Single agent?
So as Dr. Kumar Baba has already mentioned, that some previous data is not very supporting or encouraging to use immunotherapy in especially any biomarker positive patients. But if we don't have other options like PS is not very supporting the use of chemotherapy or engineering inhibitor, then I will use with proper explanation to the patient the immunotherapy.
Okay, Shruti, what's your choice after osimertinib?
Yes, sir. Post osimertinib, I have used immunotherapy, nivolumab, for patient, and he subsequently received many more lines of therapy and ultimately died of COVID. But yes, you have to be careful of using immunotherapy after you have used a TKI therapy. There is a class effect, and you have to be careful of the immune related side effects at that point when you are switching from immunotherapy, from TKI to immunotherapy, that you have to have a gap. I guess as far as the literature is concerned, immunotherapy or a second line chemotherapy is the only option that is there. And recently post amivantamab for a 20 insertion patient, I have started the AB PA regime, and I'm yet to see how this patient does. So I guess chemo plus immuno, or maybe immuno alone is the option.
Kumar?
First and second generation TKI, it is easy one. Do a repeat and hope for that you have T790M and try to get the tablets somehow.
Yes.
But if you can't, then I agree. Chemotherapy plus immunotherapy plus bevacizumab, and osimertinib, that's a problem. And theoretically, you have multiple options. You hope that MET amplification will be there, MET mutation will be there. You have 797.
Request you to conclude the panel discussion,
Yes,
as 5 minutes are left for you.
Yeah. No, we'll finish before that.
HER2 will be there, RET will be there, but in practice, hardly I find. So, I end up most of the time giving chemotherapy and sometimes giving immunotherapy plus bevacizumab. So, osimertinib, excellent drug, but subsequent therapy, we are learning. I think so with time. Sorry, I interjected. Go ahead.
No, sir, I interjected actually. Sir, I wanted to ask, my observation is that post progression on osimertinib, we don't see that many MET mutations, which we see after first and second, first generation. I don't have experience of seeing MET after second generation, but many patients after first generation I've seen a coexisting MET mutation as well as amplification, that I don't see that frequently for osimertinib. Maybe the number is also lower in the other group, but what is your personal experience in that regard, sir?
I agree with you. Post osimertinib, what we see data in the book is not what we have seen in the clinic. And we keep talking about it. Let's see, once we have, what you said is important. Once we have those 70 or 100 number, we can say about those number rightly. But yes, a bit uncomfortable after osimertinib. We want some better therapy to be available. Osimertinib per se, excellent treatment, but post osimertinib, by and large chemotherapy.
So what we do is we try to get the NGS done again, liquid biopsy. And if it is only limited MET, then local radiation can also be a choice of treatment, and continue osimertinib or systemic therapy in the form of chemotherapy plus minus immunotherapy plus minus bevacizumab. Can the triplet come in, addition of cetuximab to the combination, doublets? Kumar, any thoughts?
Sir, one should consider, sir, response is good, side effect is a problem. I'll say response is fair, I won't say good, but it is fair. But side effect is a problem. Almost everyone develops that bad rash and the diarrhea. But one should try modifying doses. I have tried in few patients, but tough to deliver. But yes, it's a fair option, sir.
So
can I just interject one? Have we tried osimertinib 160 mg type? Since we are talking about increasing the dose.
Yes.
Changes.
So 160 in CNS mets, I have tried both ways upfront, and when the CNS mets has happened or leptomeningeal disease is there, then increasing the dose. Upfront looks good, but upfront 80 also may be good. When there is a progressive disease, then doubling the dose, not so great. Not so great. Some people become better. Like there are people who said, I don't want injectable at all. Then I'm safe. Otherwise, initially I used to be bullish about it. Nowadays, not so bullish.
Okay, so the last slide from our side, then we conclude the panel discussion that osimertinib is one of the best therapy to be given first because of its good response rates, good OS, good PFS, good quality of life, in fact, better than the first, second generation, and it will be safe. And so that every patient of ours who has the EGFR mutation should go ahead with the osimertinib. That should be the first line for the majority of the patients. So anybody wants to add last comment, and then we will hand over to the Nikhil.
No, sir. Thank you. And nice to see Dr. Shruti and Dr. Nikhil.
So Nikhil, over to you. Thank you.
Maheboob sir, thank you.
Thank you.
Thank you.
Thank you, sir, and thank you to everyone for joining in. It somehow felt like it should never end, but unfortunately, it has to. I now call upon